Just some quick numbers here. Globally, in terms of the burden of unsafe care, this is what we have. 1 in every 10 patients. This is just an overview of the numbers. And more specifically, I would like to draw our attentions to the red box. This is what the numbers look like, especially for us in a low and middle income country. So out of the 5.7 to 8 million deaths annually that is attributed to poor quality of care, 15% of this, it accounts for 15% of the overall deaths that we see annually within the country, within each the LMICs. So inadequate quality of care basically costs up to 1.6 trillion yearly. I think if we look at the lost productivity that is resulting from this alone, and we realize that the cost is enormous. And by improving safety, we could yield profound economic benefits. That's up to 15% over the next 2 decades. And I think this 15% for us who are in healthcare, this is what we've been speaking to those of the governing side in terms of allocations towards the health sector budget. And think this is the common word we call the Abuja Declaration. So this is just a number. These numbers translate to livelihoods and translates to persons, those dear to us and those close to us. So this is just an overview in terms of the numbers before we dive into our topic of the day. And when we look at, for example, the global scenario, for those who practice in the pediatric setup, up to a third of all hospitalized children will experience an adverse event in one way or the other along the journey of the healthcare. So as we look into building systems that are ripe and are able to serve us within the 21st century, the global guiding framework is the Global Patient Safety Action Plan. And from this action plan, basically it provides us as healthcare organizations and as frontliners with strategic focus for safety programs. It's basically the blueprint that enables us to focus our safety programs. And it also gives us that opportunity to imagine how we can develop and design safer programs. Let's say now in view of violations as the topic that we are going to handle today. And within the action plan, we have interventions across 7 key areas. It's usually called the 7x5 matrix. And our today's sessions, we are basically delving into the first 7x5. And in the first 7, we'll be talking about patient safety with regards to policy, strategy, and implementation frameworks. And also in terms of the second strategic objective around high reliability systems, because safety systems are basically supposed to be designed to enable the system itself, the health facility, the organization to be reliable and also to provide it with that resilience in space and in time. So that is the global anchoring framework. And amidst all this, especially for us in the LMICs, as much as health systems are facing challenges. So yes, even in the high income countries, they have their challenges. But for us in the LMICs, these are some of the challenges that we face. We are constantly faced with high workload scenarios. And these pressures, the production pressures, resource constraints, hierarchies, and the dynamics that are the things that drive the adaptations, the migrations that we are going to look at. And we've seen the number in terms of what unsafe care provides or gives us into the system. We've seen the numbers. And traditionally, we always approach it with a zero tolerance approach. And I think that is what we see mostly within the healthcare organizations. We profess that we've got zero tolerance to, for example, to errors, zero tolerance to violations. And often we are driven by a fairly punitive approach in terms of managing the errors at the workspace and also managing the violations at the workspace. But in most cases, what happens is that these approaches just act as enablers to drive these errors and violations underground. We may not see them now, but they're still there. We may not see them, but they are still there, simply because of the approach that we take in terms of managing and approaching errors and violations within the systems. So the 21st century healthcare system basically requires us to shift from the blame culture to more adaptive and more resilient safety systems. And that is what our session today is basically talking to. And just key concepts here that we will be looking at. Violations, for us to speak into violations, we also need to speak around errors. And the taxonomy, the naming here that we've used is based on James Rison's classifications of errors. And this is where in errors, you'll have those intentional slips, you'll have lapses, and you'll have also mistakes. And these are usually also further classified. For example, for mistakes, you'll have those the rule-based mistakes or knowledge-based mistakes. So a knowledge-based mistakes is whereby maybe you make a mistake simply because you do not have the sufficient knowledge to handle the task at hand. A rule-based mistake may be because you deliberately ignore the rule that has been placed in the system. So that is what we'll be looking at. And for violations, this is where our main focus will be. Violations basically are deliberate deviations from the rules and procedures. It's a sub setup in terms of the taxonomy of scales, the naming of scales from the errors. So violations basically now these are deliberate deviations that we make and we do every day. And violations are pretty common and mostly more common than errors, and even more so in the systems that we say that are safer. These violations, one, they have both negative and positive aspects in that through some of these violations, we increase performance or enhance performance efficiency, or we also enhance satisfaction from the healthcare workers or even from the patient's side of it. But the negative aspects of it, this is where we should be looking at and focusing our design systems around, because the negative aspects means that we are constantly exposing ourselves to risks of harm. And when you look at these violations, should not just take care of to look at them as or term them as bad behavior. Usually what happens is that when these violations occur, they are a marker of what the system is undergoing. So if the system is undergoing an adaptation and you see a violation, it's not just bad behavior. It is essentially what the system is going through. And that is what we are going to look at in terms of how does the system navigate itself when it's going through these violations, and how can it get better. So with that, we are going to look at it from the model of the framework that was proposed or that puts across by Malbati and Rasmussen. And in this framework, if we look at, let's say, an XY axis, and you'll have our performance, for example, let's say the stuff that we perform based on that are purely driven for personal gain. And personal gain here would mean something like you want to get the work done with it and then get to the next patient. That's a personal gain. Or a personal gain would also mean that you'd want to get that next level of performance. That's a personal gain. On the other side, you'll have the performance as it proceeds, as healthcare workers over time. And let's imagine in the framework, let's imagine 3 zones. If there is a first zone, there is a second zone, and there's a third zone. So let's imagine these zones and walk through, see how stuff happens. So in the first zone, this is where as we imagine or design protocols or safety systems, this is where we imagine that every healthcare worker or provider should be operating in. This is where we have our code of conduct, the scope of practice, the rules and the protocols, and all those system barriers that we may be having. And the expectation is that, or workers imagined, is that every healthcare professional should be operating within this space. This is the space, for example, performing a procedure within your scope of practice. This is the space that legally we are expected to. And workers imagined expects that 100% of us should be operating within this space. While that is what we expect, with time or given the scenarios that we face within each and every workstation, you'll have issues around production pressures. For example, you are in your consultation room, you have a queue of 40, 50 patients to see. You know, that's a production pressure. Before your shift ends, you need to have taken care of them. And another pressure point should be around policy regulations or deficiencies. For example, in deficiency, if there's no clarity on the scope of practice on what you should handle at what point, just might be around technology, also maybe applying some pressures on you. For example, there's a new EMR system that has been introduced into your system that requires you also to place your prescriptions and your medication orders through it. And navigating some of these tools might be a challenge for most of us. It's not straightforward as we imagine. And we may also have individual and social forces. You want to get the shift done with before 5 p.m. because you have a birthday party coming in and you've booked yourself at a prestigious location that you do not want to miss. You do not want your guests to miss you. So that's a social pressure. Or probably over the weekend, you had a road trip somewhere across the country. You're coming back and you're feeling you're not up to the game yet, but you're still yet expected to work. And also infrastructure and resource constraints and limitations. So these are the kind of pressures that now will determine how far we operate or practice within the first phase of things. But it does not happen as imagined. And that's where now we step by step slowly drift into now the illegal normal. So in the illegal normal, these are basically the borderline tolerated conditions of use. Yes, we tolerate them. We know we should not get to that level, but for one reason or another, it helps us get the work done. So for example, you may be pressed for extra hands at the immunization desk. You are at the MECH and you are pressed for hands, and you've got a few extra hands that you think you can count on, whose scope does not include providing injections or providing injectables. But due to the fact that they've seen you do it in most of the times, it's an illegal normal. Yes, they can do it under your supervision. You are there, you see. And in one scenario or the other, you may see that, okay, something was about to go wrong, but you nipped it at the bud. So for example, you may realize that, oh, the injection part or the positioning or the type of syringe or the dosing was not appropriate. You nip it in the bud simply because you're there. So those are the near hits or the close calls. Because if you're not there, the call will be made. That means the inappropriate injection will be made. So this is the next phase. And remember the production pressures. You have 30 or so babies to immunize on the immunizations, on the immunization desk. You've got insufficient hands at play. So that is how the production pressures basically would be moving you towards the borderline tolerated conditions of use, and realize that in most cases, this is where we operate in. 80% of the time, 50 to 80% of the time, most of us operate here. In the next phase, we'll be looking at now the phase 2, the forbidden spaces, except under extreme pressures or conditions. This is where we should not go there. But when it calls for it, we can get to that, we can get to that point. So they are fairly illegal, but we tolerate them in a way. We know that we should not go there. For example, a wrong side surgery is an illegal, but sometimes we may get there due to the pressures that we've highlighted here, or the demands that we've highlighted here. And we'll have a few moments where the wrong side surgery does not cause extreme harm, does not cause harm, but there are also those moments that it will cause harm. And that's where now we have the patient harm and adverse events and adverse event safety leading to a safety incident. Next to it, the last phase now we are going to the third phase where everyone knows conventionally, everyone knows that that is a forbidden area. That's not a space that you should go into. This is the phase where you do something and even your colleagues are astonished. They say, wow, how could that happen? How could a doer do that? So basically, that is now the third phase. So these progressions or these migrations happen over time. By the time a policy is put in place, in the next 2-3 months, due to production pressures, due to commodity pressures, due to technology issues, or just social and individual forces, will be drifting away from what the policy requires, or from what the protocol had required, or from what the system defenses are able to contain. So this is what happens along the way as we progress towards those risky practices. So within this framework also, there are also that a solution space, which solutions you can pick at what point in time and how you can move with them. So the first action area is first that do we accept these adaptations and protocols, that the adaptations to the protocols. And one is being alive to these violations, being alive to these migrations, and is the first port of call in terms of generating your solutions. Number two, get to adapt your defenses and in a proper way that you can always, maybe sometimes you adapt the defense and then you reject any other mitigation. And sometimes we just choose to suppress the triggering conditions of the migrations. And sometimes, as a solution point, among all that, you may add extra defenses or extra layers. Sometimes you just add extra layers and apply a blame game. So this is mostly how we've been handling, we handle these violations and migrations over time. So when we look at this, the model that we've looked at, you realize that migrations occur over time. And in the phase one, this is where we are mostly looking at the formal situation, the formal rules and the protocols. When we get to phase two, we'll realize that we have borderline tolerated conditions of use. And the normal illegal stuff, it's routine minor violations tolerated for some benefits that might be benefiting the system or the facility itself, or might be benefiting us. For example, the idea of getting the queue done with, it benefits you in a way and also benefits the system. So that's why we tolerate some of these BTCs use. And that also goes to how we get over time to normalize this kind of deviance. And that is now what pushes us, especially for lack of a better word, the reckless individuals to drift towards the more riskier practices. And in most cases, you will find that the riskier practices, the drift is mostly usually driven by personal gain and personal benefits. So when you look at this, you need to understand that systems will always migrate towards those boundaries, basically based on because of the pressures or the issues that we've highlighted. So systems will always migrate, and it's a natural occurrence. And the main call for action here is that As system managers, as healthcare workers, as frontliners, we need to be alive to these migrations as they occur towards the riskier side of practice. So this is basically a snapshot of why the system migration happens. Performance pressures based on the organization or based on the individual themselves. Basically also taking in mind, let's say, for example, the social pressures we've spoken about. They happen because of our overly rigid and unrealistic rules within the system. So here, whenever we get our protocols or our guidelines or our SOPs in place, we bundle everything together, not knowing that, okay, there are those that are nice to follow, and there are those that are essential. We should not miss to reinforce those that are essential, that are now goes on. Those are basically essential for us to get through it. And then anyway, the benefits of shortcuts is something that uh, as healthcare workers in the front line or as management give us that extra relief, yes, in terms of the speed of getting work done or the reduced workload on the front line, or just in terms of from the management perspective, just seeing more. So those are some of the reasons why we see them. And migrations or these deviations, they occur gradually. The deviation today that was in phase 2, over time, it moves us to phase 3 or to the more risky side of things. And in most of our setups, for example, in most of our setups in the LMICs, we face staffing shortages, commodity issues, and also high patient workloads. So these are some of the practices or some of the scenarios that enable migrations towards the boundaries of the risky practice to occur over time. So in terms of mitigating these migrations, I think these are just a few of the frameworks and concepts that we may be highlighting in some of our future sessions. So just a snapshot, we'll be interacting now the human error approach and the Swiss cheese model, how to reinforce and how to reinforce, rewire, or reinvigorate or restructure the system defenses. And now the other concept basically will be looking at how to instill or enable patient safety organizations within the organization so that everyone else is able to speak and able to say up. So for example, when someone sees a violation that is becoming or moving to the risky side of practice, each and every one of us should be in a position to speak up and also make a correction or just question whether this deviation is helping the system or it's moving towards a risky place for the patient safety program. And also enable a just culture. This in just culture, what we mean basically is that we apportion blame where it belongs, and we apportion recognition or celebration or recommendations where it belongs. So when the blame or the shortfalls, the shortcoming belongs to the system itself, we apportion it there. But when it belongs to the individual themselves, we apportion it there. And when we will be talking about that, you'll see the various approaches on how to handle each of them. And the main goal here is to enable us build systems that adapt towards enabling systems and recover in the midst of violations that are beyond safer care. So these are just some common practice, some patterns, some common patterns in the subspecialties. So for our colleagues who are in maternal care, these are some stuff that you might have seen, for example, task shifting or improvised staffing. And in improvised staffing, for example, here, we may have support staff within our work system. And with time, the support staff has observed and overshadowed and shadowed the experienced midwives as they support the perineum during the delivery process. So with time, when we have one midwife on call on the shift, and we have 3 moms who are on labor, we may have now the support staff coming in to support. So that is, it's usually a point of migration. And uh, we acknowledge or we tolerate them simply because it helps us to get the work done. Only that it now places the risk on delayed intervention. For example, uh, the signs of danger that an experienced midwife would pick while supporting the perineum, uh, the support staff or any other person coming on to support might not be able to see that. For example, signs of danger that will pointing towards maternal hemorrhage, PPH, or neonatal asphyxia. So these are the kind of how these migrations happen, and maybe just an example within our spaces. For example, when you look at cash before care, and I think within our poll, we had seen something around that. For example, before you get that PPH kit or bundle for you to go to theater, the mom is supposed to pay up some fee upfront. For example, before the payment is made, the mom still has to wait. So that is an example. And sometimes, for example, overcrowding or early discharge. And in our maternity spaces, we find 2 or 3 moms, maybe 2 moms on the bed. They are on postnatal unit. Yes, they delivered their baby safely, but due to overcrowding, or we need that bed space for the new mom who has just delivered. We'll now say, okay, you two are stable, you can bundle together. So what are the risks here? The risks here are basically now increased rates of infections or perinatal infections, as we may call them. And in terms of mitigations, what we need to do here, one, we need to standardize our task shifting protocols. And with this, you also need to infuse into the system of appropriate supervision tiers. Whichever roles we want to task shift, they should be formalized. And then appropriate mentorship and appropriate supervision tiers. When you look at the supply chain resilience issues around that, we can implement prepackaged kits or bundles of care, and also ensure that within the supply chain we have adequate buffer stocks to enable and support community-based distribution, for example. And when you look at now for fee before care, this is where now, for us in the LMICs, where there are government subsidies, we need to find mechanisms to take advantage of that and utilize those. And also, one also apply basic ward management tools in terms of what are your capacity thresholds, what are your do you have a system for early warning, an early warning system, or do you have a structured handover for, let's say, a discharge protocol, a structured discharge protocol that enables the system manage its numbers properly and effectively. In surgery and perioperative care, these are also some of the common examples: extended reuse of surgical instruments and sets, and sometimes due to the pressures of time and the overload of the, let's say, the theater list, the overload on the theater list, we may not have that adequate. You may say that due to the instruments, the packages that we have, we may not have adequate time to conduct proper sterilization or proper processing. And also due to resource issues, we get ourselves using one-off instruments and uh, in between the cases. So here, we mainly tolerate them because it helps us to manage the throughput or the outcomes of care within the facility. But as a risk from the other side of things is that this is where now you'll constantly seeing yourself having more surgical site infection rates. Another one is improvised anesthesia or anesthesia or monitoring of anesthesia, where you have, for example, spinal anesthesia with suboptimal dosing, or you're proceeding without full monitoring equipment, but you feel that you need to proceed and get the case done with. fairly common in our resource-limited settings, and we know that the risks that awaits us on the other side of things. So task shifting in operating or in the operating rooms, this is very, very common. For example, non-specialist physicians or clinicians performing serious cesarean sections or emergency laparotomies, simply because one, let's say the supervising senior or consultant, we're still not within reach, but we just want to, when we want to get the work done, and for the benefit of also enabling them, the person or the patient access the care. And the risks here is that we are now constantly facing high complication rates and also adverse event rates. The other common practice within the surgical and perioperative care is postponing cases or batching elective cases on a specific day, simply because we want to manage with the, let's say, lack of appropriate time. We want to manage the time of the consultant who is coming, or the time of the of the commodities within the commodities that we have, we want to use for the same day. And here a case in point is that we've heard of those kits, or those let's say, if you've got a vial of an anesthetic drug, let's say it might be bupivacaine, you want to ensure that when you open it, you are able to serve a number of patients with it. So you find that you batch your cases to ensure that you are able to do that. So some of the mitigation approaches in terms of sterilization and instrument management, basically introducing low-cost and validated processing guidelines, instrument use, and in terms of anesthesia safety bundles, basically develop context. You adapt this to your context, the safety bundles, to ensure that you are able to take care of your patients within the available resources that you have within yourself, within your system. And then in terms of managing the operating rooms and task sharing, designing basically appropriate referral systems to basically in line with the surgical capacity of the facility. And then in terms of batching or postponing cases, just a management approach for theater efficiency without compromising safety. If you have applied better scheduling tools and also backups for system resources that you think might be lacking or might make you to defer care. So the last example bit is on emergency care and critical care. I think we usually have triage deviations, overcrowding. You bypass formal triaging or admit beyond the capacity in emergency department, stockouts and workarounds, substituting antibiotics with or fluids with alternatives, or or rationing oxygen sets or IV sets, or just delayed referral systems. You keep an unstable patient longer at a lower level facility. One, due to the transport cost, you may be waiting to batch the patients, or simply because for lack of a better better monitoring system. Here, in terms of mitigations, you should be looking at triaging and capacity management tools. These are what you need to be implementing within the system. Implement better or local contexts, contextualized capacity management tools for your organization, for your facility. And in terms of rationing and substitution or guidelines, you need to basically develop the essential commodities or medicine lists within the organizations and their approved substitutes, so that the list and the alternate or the substitute is processed seamlessly through the supply chain systems. And also, basically, for example, instituting antimicrobial stewardship program just to curb one, overuse and also misuse within the system. System strengthening for referral systems, just ensuring that you have a better communication, or just might just be about communication protocols between the receiving facility and also the referring facility. And monitor your early warning systems. You may need to have early warning systems within your system. So what are these signs that would trigger this kind of actions across maybe not only for emergency and critical care, but across even for uh, the inpatient units. So some of the ones that we see in the pharmacy and the outpatient units, antibiotics or overuse, improvised regimens. We see these a lot. Medication dispensing shortcuts, the multi-dose vials beyond safe periods. We see these a lot. Splitting tablets. We see these a lot. And this is where now, yes, it gets the work done, but the risk of it is that it builds resistance. For example, antimicrobial resistance within the community or within the population that we serve. IPC lapses, reduced hand hygiene, or cohorting infectious patients together, and that's where you say, okay, there's a space, a separate, let's say, waiting bay, that for those patients you suspect to have TB, you direct them there. So that's also that's also a borderline tolerated conditions that we see. Overuse or over-reliance on clinical diagnostics. So this is where, due to maybe resource limitations, we skip labs or imaging, or due to cost limitations, we skip labs or imaging, and then we go along with a clinical diagnosis. For example, in respiratory care, we will see a clinical diagnosis for a TB patient, or you'll see a clinical diagnosis for a malaria patient, and then proceeds to, let's say, the dispensing window, gets the commodities, gets the medications, and goes. So what we look, the risk here is that, yes, we get the work done, but the risk here is that we are progressing towards uh, building up resistance within the community and within the populations that we serve. And then, for example, a common one is discharge against medical advice. Yes, as much as it's a right of the patient, but you'll realize that within the same facility or the same hospital, different nursing managers, different clinicians, different consultants approach DAMA in a different way. So the mitigation here should be like, for example, you need to standardize your approach to discharge against medical advice, and also add a layer on it in terms of the follow-up care, the continuity of care aspects. Maybe it might be through our CHPs, or it might be through just a simple SMS. In terms of improvising regimens, we need to now better strengthen our antibiotic stewardship or antimicrobial stewardship, and dispensing safeguards. We may use this by training rapid diagnostic, or enforcing dispensing logs, or just a use of prepackaged unit doses where possible, so that we don't get into split medications or splitting tablets as currently, as in most cases occur. In terms of supply chain forecasting and community involvement, we need to get to a level whereby we start using our data more, so that our procurement is data-driven. One, we don't procure what we are not utilizing for the community we are serving, and also limit reuse of commodities as much as possible. In terms of principles of mitigations, these are the key principles that you need to have in mind. Accept and monitor the migration. We need to know that migrations are there, and accept this. And those borderline tolerated conditions of use are usually just a signal that the system is under stress. For that support staff helping the midwife to hold the perineum, that's a signal to the system that the system is under stress. And we need to balance performance and safety, whereby try as much as possible to reduce external pressures and reinforce informal safeguards within the system. And these informal safeguards in a matter of, let's say, psychological safety might just be empowering that, let's say, junior nurse or junior clinician to speak up and say, yes, this and this is happening, but is it helping the patient to get better care? So are the informal safeguards that we need to be put in place. And then context-specific participatory design involve frontline staff in redesigning the processes. In most cases, when we redesign the processes and our protocols, we may not have the frontline staff engaged through and through, because mostly this work happens in the frontline, and it is us or those in the front lines who understand the processes better than those in the management. So we need to engage them and then build resilience, emphasizing that the failure to rescue capabilities of the system and the team situational awareness, building this into the team so that we are fairly situationally aware that yes, within this shift, the number of staff on shift may not be able to sufficiently take care of the patient population that we have. Also, rapid recovery over pure prevention. And then we need to have this multi-level, you combine various approaches, the structural one, organizational ones, and the individual approaches and team-based approaches, so that we have a multi-level mitigation approach for this systems migration. And still on the mitigation principles, cross-cutting strategies here, we use KY and your learning systems as much as possible, because what you track on the dashboards is basically a sign that yes, you may have some BTCUs in place, but they are giving you a signal, an indicator that your system is under stress. Now that's where you apply KY principles and the learning systems to see how can you better improve. Workforce and culture interventions, adequate staffing ratios, fatigue management for our staffs, and also team training in terms of response to adverse events or response to emergencies within the team setup. And we encourage you and facilities to build better environment to enable psychological safety. Policy and financing levers. Where finances are required, we need to unlock these finances. Where policy is required, we need to unlock and align these policy areas or protocols. And also in terms of technology and innovations, we may make use of low-cost digital tools that are available to us. It might not need a software designing. A simple SMS system might be better in terms of reinforcing or strengthening that continuity of care when you're looking at now strengthening your referral system. The referring and receiving facility, just giving back a simple SMS, the patient was received and we are on course. Or regulatory adaptations where necessary. So that also here with regulations, we need as much as possible to move from rigid risk-based obligations regulations and towards adaptive regulations that define acceptable boundaries and compensatory care. Lastly, these are in terms of still on the principles, the practical approaches, routine observations and team dialogues. This is very low cost. You don't need much investment here. Analyzing incidents for migration patterns, very low cost. Tracking workarounds and near misses, using simple tools, the safety hurdles, the debrief that we are having within the organizations. And just when you look at routine team dialogues, just a simple question for the team: is this adaptation helpful? All drifting towards risk. Those are some of the things that we need to do. And remember, we had the 3 phases. In phase 1, we design realistic and prioritized rules involving the staffs. And in phase 2, where we are now entered borderline tolerated conditions of use, we want to know these beneficial adaptations. We need to formalize them. And then also we strengthen peer norms or peer-to-peer feedback. And then in phase 3 now is targeted interventions for those outliers. Training where necessary, we support with the system restructuring, or disciplinary cases where necessary. So generally, we need to relax non-critical constraints and reinforce core safety barriers, and also build a system where our team members are able to have open discussions around the risky practices. So just a word here, we start small, one ward, one unit, or one working space, and then we integrate this into the existing training and career programs that we have. And as managers and leaders, we also need to model these behaviors that we want to instill within the system. We combine this with the patient safety priorities with the WHO, for example, the human factors issues, the just culture issues. So this should also be embedded in our approaches. And these are fairly low tech and high engagement approaches within our facilities would get us more. So next, lastly, just that capacity building. Yes, as always, you infuse your capacity building to ensure that you are able to sustain whatever you are bringing into the system, and you link this to the various career progression systems that you have. You may, from safety champions to your QI and patient safety managers, measure the cultures, measure what is happening in the system through safety culture surveys, incident patterns, or patient or staff engagement. And also you reflect, you enhance organizational learning through reflections on improvement, just having a moment to reflect on what has been brought into into the system. So these are some key enablers: psychological safety, distributed leadership, and realistic protocols and targets. Those are just key enablers, and this is basically what we'll be looking at in terms of the outcomes: improved incident reporting and learning, reduced harmful events while maintaining efficiency, higher staff motivation, especially when staffs are engaged in designing some of these safety systems and safety protocols. And overall, we are looking forward to building resilient teams within the resource-limited environments that we practice in. If we were in a workshop setup, this would be a question for all of us. So just now that we are not in a workshop, but just by the way of chat on the chat box, you can uh, just respond on one of these questions. Any BTCU in your setting that you've seen, and maybe a proposed management. And yeah, so this would be appropriate when we're in a workshop setup, but that's just takeaway. And then lastly, these are some of the resources or materials that we've used for this session. The Human Error by James Rison, the Global Patient Safety Action Plan, the Fearless Organization for Psychological Safety, Safer Healthcare Real World Strategy by Amalbati and Charles Vincent. And then the publications still by the same Amalbati and Vincent on violations and migrations in healthcare. So the framework we've highlighted is basically is work done by Vincent and Amalbati. So those are basically the references, and just a summary. What we need to take home here is that human beings will never comply with rules, and deviation from procedures is basically a normal thing. It happens in all industries. So reporting systems are largely ineffective in monitoring more serious violations. So what do we need to do? One, acknowledge that violations are there. We cannot eliminate them, but we can manage them. Dialogue between the frontliners and the management is a key factor in establishing a shared safety culture. And two, the largest gaps in compliance are those that remain undetected. If we don't detect, we don't see them, these are the undercurrents in the system that surprise us with those patient harm events. And lastly, establish effective peer protocol. And this can only happen if we've established a safe environment for everyone to speak and everyone to apply some level of control within the teams that they work in. So that is the closing comment. So as always, if you've been in any of our sessions, we like speaking to elders. And when we speak to elders, we pick one thing from the elders. And this is on Elders Coach. For today, we have Dr. Renea Malbati, whose framework we've been discussing around. And what he says is that the protocols that we design, that is the work as we imagine it, they really match what happens in the workspace. So system migration is a natural result of the workers just trying to modify the system to close the gaps that they realize they're seeing. So violations are part of the system. We can never eliminate them, but they'll always be part of the system. So how we manage them is the question. So thank you so much, and I hand it over back to Grace.
Oh, wow, wow. Thank you so much, Odur, for that very, very insightful presentation that we have just received. And I believe most of us are inspired. I want to leave this time for questions. I've checked on the chat box and then I realized someone has just commented, this is very new. I didn't get it in school. Let me just read it from Geoffrey. I hope you'll keep on training us. I never came across this knowledge in school, and so we will keep on doing that. Let me give a few minutes. Let me give like 30 seconds for someone who wants to ask a question. We could also just utilize the chat box so that we're able to move fast. Any question? I noticed this a really, really new area, and thank you so much, Dwar, for bringing it on board. I know most of us are really trying to, reflect over it. But I'll give some few minutes. Any question from our participants? Meanwhile, as we wait for the question coming, I want us to go to the React button and just appreciate Odur for that really very, very insightful presentation. You can clap your hands, you can celebrate. Let's really do it as we appreciate. This is really knowledge that we could have paid for, but it's coming to us really at such a time. Yeah. So that's powerful. Let me just read another comment from Chris Moranga. Yeah, that is a powerful presentation. I'm new to how regularly do you have such CMEs? I think that is what he meant. Do you do such CMEs? So probably you'll react on the same. Stella has also shared a link there, so probably for Stella, is this for the post post survey?
Yes, that's for the exit survey.
Okay. Yeah, so we could do that. So Odur, just coming from thinking about the hospital setup as we wait for others as they internalize this, I'm just thinking, how do leaders in the healthcare setting distinguish between acceptable adaptation and also unsafe workarounds? Then number two, how can hospitals, like now for people getting this for the first time, how do they go to recognize that they're already experiencing system migration before the adverse events occur? Those are some of the a few questions that are ringing in my mind. So probably someone might also be thinking about the same. Probably you could react to the first three, then we can see if others are going to come. Yeah, thank you.
Thank you, Grace. So when we look at the migration happens or occurs in a journey, and when you have a policy, for example, let me give a common example that I have seen around. When you give, there is a requirement that one needle, one syringe per vial, so that the vial doesn't get contaminated over time. You may not realize that this is a borderline, or this is a violation, or this is a violation that is moving towards that borderline to related condition. So in most cases, we have reached the level where it is tolerated in that you'll place one needle on the vial and keep on coming up with multiple syringes. Some are fresh syringes, some are syringes, reuse syringes. So you realize that that is a violation, and it happens progressively. The first day you do it, the first day someone does it next to you, it might be new, but over time you get used to seeing that needle on top of that vial, where you can just come back with your syringe and draw, for example, a medication or a fluid, whatever you want to draw from that. And in sometimes, if you are in the middle of an operation, for example, let me speak, let's say a case for, let's say you are administering anesthesia and using a single vial of bupivacaine. You placed a needle on top of it. Maybe during the procedure, you may withdraw from the same vial using the same syringe twice or three times. And again, you may have another procedure planned thereafter. Now you come back again, the same needle is still there on the vial. You'll still come back with a new fresh syringe, withdraw from it, and also maybe during the procedure or another 2 or 3 times. So those are violations. So these workarounds, one, they help us, one, in terms of managing commodities, the countless needles or the countless syringes. It helps us to manage commodities. So we tolerate them because of that. Two, we tolerate them because also it makes work easier for us in case of just using a needle every now. So the first point is being aware. What in patient safety we call error wisdom, being aware or violation aware that this is a violation. So before you are aware of it, you may not realize that, yes, we are drifting or we are migrating, okay? And this one also happens even in maternity care. The first day, yes, this overwhelmed midwife calls on to the support staff. Yes, have you seen how I've held? You just take this, goes, place it here and press firmly. So with time, that's a migration in motion. So if we are not aware that there is something called safety migration, safety system migration, or towards the borderline tolerated conditions, you may still not recognize it. So that is one to you. And then to our management, for the management, one way to realize that you are having migrations in space, one is this. Looking at for example, the capacity of the unit or the capacity of the MCH in terms of workforce staffing against the volume of work that gets done. That should be signal enough that your system is under stress and there's a migration that has happened. There's a migration that has occurred to enable them to give this output of output of care. Because you will routinely see us interrogating or reading the data. For example, you don't ask yourself how one nurse on duty was able to let's say to immunize 30 or 40 or 60 babies in a day. And some of them were first timers on BCG, and some of them were on the Penta vaccines. So you will not ask yourself how one nurse on duty was able to do that. So the moment you are aware, self-aware, you'll start realizing that your system is migrating. There's a condition of use that is being tolerated within the system. And one, we are tolerating it because it gives us the output for the organization or the facility, and also the output for the staff. So those are key moments where, as management, you can be aware of those violations happening. For example, if you are running a surgical unit, let's say maternity and surgical unit, and you constantly find that all elective cesarean sections are pre-planned on a single day, that's a signal of system or of a migration, whereby the reason for planning all of them on let's say on a particular day, one, during that day now, the workforce there is under production pressure to take care of all the cases that are on the list. So within that production pressures, that is why when you now start realizing that, okay, there are some workarounds that are happening here. And if you are not aware of the idea of migrations within the systems around safety, you will not see that. You'll see that as a routine care approach. But those are usually signals that the system is under stress. They are finding better ways to cope. That is why they are putting, for example, they are listing all their electives on a particular day. So those are basically just some insights around that. And they are pretty common. The violations are pretty common. So for example, let's say for our colleagues, we may have colleagues who work in an oncology unit. And for example, you are working in an oncology unit, there's this patient that needs to receive an intrathecal chemotherapy and an intravenous chemotherapy. And maybe the protocol says that they should receive this on alternate days. They should be prepared on separate locations. But due to the pressures of staffing and time, they are prepared on the same day or the same space by the clinical pharmacist or so. And then instead of this also now being given on alternate days, you as the oncologist or whoever is administering the medication, you say that instead of me coming tomorrow again to provide it for the same patient, or instead of making the patient come back again, transport is a resource. Instead of the patient coming back again tomorrow for it, we say, okay, let's administer this on the same day. So it's a borderline to related condition of use. With time, it will progress well, but now, maybe a particular one instance, instead of doing your methotrexate intrathecally, you apply it intravenously. And instead of doing your vincristine intravenously, you apply it intrathecally. And those are very serious harm events that usually happens, for example, in the oncology space. There are so many of them that happens. So the moment you see you are veering off from what has been prescribed without it being formalized, that's a migration that's already on course. Yes, Grace, I believe I've responded to the questions.
Yeah, sure.
Yeah. A question.
Yes, Geoffrey. Go ahead.
Maybe is there a percentage allowable a percentage? I mean, an allowable percentage of borderline. What do you call it? Borderline related condition of use. So because we may not probably avoid it fully, or is it possible to avoid this fully? And if not, what is the allowable percentage for borderline tolerated condition of use? And then the second question, one of the, I think, cure or some of the reasons, the solutions you gave was there was something called James reason, human error and use case model, and psychological safety. Let me talk about James reason. So is it a book that if we read, we shall get more information or what? Thank you.
Yes.
Okay, thank you.
Yes,
Over to you,
Human Error by James Reason is a book. Human Error by James Reason is a book. So if you get to read the book, it basically, it instills in you the first aspect we call error wisdom, just being aware that these things happen and being aware that, okay, what I've been doing, are drifting towards borderline tolerated conditions of use. And number two, on the other question, and that applies to all the reference sources, there are materials that you can read. And then number two, in terms of the allowable percentage, what is required here, remember we said that violations are part of the system. We cannot eliminate violations. But the key questions that we need to be asking ourselves with each violation is that, one, how far or how better is it serving the facility in terms of patient safety and also the organizational capacity throughputs? So you'll realize that if a violation that has drifted to a borderline tolerated conditions of use is has been assessed to provide benefits. Remember when you talked about the violations, there are those that are beneficial and there are those that are harmful. Those that are beneficial, what we need to do is that we formalize them. And if it was, for example, a case of task shifting, we formalize them, and whoever the task has been shifted to is given better capacity building also to go along with the task that has been shifted to them. And also, we now apply appropriate, let's say, tiered supervisory or mentorship skills to ensure that, okay, the task shifting does not end on one event, but it's an ongoing mentorship process. And there's always now in the line of service, there's an available mentor or supervisor to step in. You remember the close call, for example, the close call I gave with MCH, when you realize that your student nurses are not able to provide BCG vaccination to the baby effectively, whether it is in the right types of dosing or the appropriate dosing or the appropriate site of injection, you as the senior nurse or mentor working with them, you are within close proximity to address that as it happens. So that is what we need to do. That is now formalizing the violations or the borderline migrations, the migrations as they occur, so that it helps. We realize that we only now keep the migrations that are conferring patient safety and also supporting the organization or the facility goals. And that means that we also reinforce or strengthen the peer-to-peer, the peer-to-peer support, whereby your colleagues next line are able to see a violation and also able to arrest it or mitigate any untoward action that might now lead us to, let's say, a close call or a patient harm. So, Geoffrey, have I responded to that, I believe?
Yes.
Okay.
Okay, thank you so much, Odor, for the response. Geoffrey, if you're well answered, any other questions? If there are no questions, I just wanted to pose again one question to ask. Based on what we've learned, do you think the facility that you come from, you are able to report deviations without creating fear or blame? Just tell us yes or no in the chat box. I would like to see what your thought is, just to know where we are. Are you able to report, violations, especially the negative ones, without that are not beneficial, creating fear or blame in your organization? Then lastly, Odur, if you'd recommend one patient safety intervention in every hospital, that every hospital should prioritize this year, what would it be? One patient safety intervention every hospital should prioritize this year based in our low and middle income context. What would this be? As we get other reactions in the chat box. Let me see your responses on the chat box. Yeah, thank you. Over to you, Odur.
Thank you, Grace. In terms of patient safety intervention, let me begin by just highlighting and informing our colleagues that this year for patient safety action or activities, the WHO has narrowed down on chronic care facilities, or NCDs as it says. We are looking at strengthening safety or patient safety actions or intervention around NCDs and chronic care. So that is a good point or a good intervention to look forward to as the year goes. Maybe by the by the time we celebrate World Patient Safety Day in September, key intervention approaches will be coming across. So number two, to the one patient safety intervention. When you look at the global patient safety action frame, it has the 7 strategic objectives, and out of those 7 strategic objectives, the WHO has also crystallized them into some ready to pick and ready to implement interventions around patient safety, called the patient safety goals. And they're usually about 6 in number in terms of patient identification. If it is just enhancing patient identification, ensuring that the right patient receives the right commodity or the right service or the right care, that would do a whole load of difference, will give you a whole load of difference in your unit. Whether you are just talking about the right medicine for the right patient at the right time in terms of medication safety, that will do you a whole load of differences. Whether you just want to provide your intervention around patient engagement, how you get feedback from your patients and how you act on their feedback. So those can be some fairly easy aspects to start from. Something as basic as patient identification. I think this is one point that if any facility starts with that, you realize that you are getting more and more closer to safer care, because it's based on patient safety, patient identification, that you'll miss that wrong side surgery. It's based on patient identification that you realize that the commodity is not right for the patient, or the medicine that you prescribed, you are administering is not for that same patient. And it's the same patient identification that will make you, as a healthcare provider in the front line, realize that, okay, yes, today's consultation or today's review was not for this particular patient, but for patient B or patient C. So that is basically a low-level line that I would put across as an intervention.
Wow. Thank you so much for that beautiful response. I've only received feedback from 2 people, Gladys and Chris. Florence also asking, will we get CPD points after this session? Please keep the questions, the answer coming. I asked sincerely, when we do an appraisal on ourselves and within the facilities that we serve in, do you think you are able to report violations without creating fear or blame? And just a simple appraisal on us. Please let me get the responses. Florence, I'm waiting for yours, and the rest of us, at least so that I'd be sure we were getting something. Just tell me whether yes or no, because that is very, very important. Thank you. I've also seen your response, Geoffrey. Keep them coming. Before as I wait for your responses, before I hand over the mic as we wind up, I want to really take this opportunity to just thank you so much, Odur, for sharing your expertise and practical insights with us today. And also just extend our sincere appreciation to all our participants for your active engagement, the at least thoughtful comments and even questions that we've had on the platform, and also committing to improving patient safety. By you even joining this, we know you are committed to that. At Systems Evaluation Limited, we believe in safer healthcare systems that are intentionally designed through continuous learning, through strong governance, and through a culture that empowers healthcare workers to improve care every day. So we encourage you to continue applying today's lessons within your organization. I know someone asked about if this will be frequent, even as I leave hand over the microphone. We'll still be having more of these. I know do really elaborate further on this, but just to also let us know the interventions that we have at systems evaluation. We service intentions by building sustainable programs, building lasting solutions, building better health systems. And that is really our passion. So our self-service areas are safety and quality governance, revenue cycle management, research and learning. So feel free also to engage with us. We'll be leaving the contact so that you're able to reach us at the website www.systemesevaluation.co.ke. I think they were projected on the screen at some point. We're also on LinkedIn, also Facebook, also X. You can get us there. So I want to say thank you. And on behalf of Systems Evaluation Limited, thank you once again. Yeah, that is projected on the screen. For joining us today, we wish you you continue advancing safer healthcare systems within your organization and have a wonderful, wonderful afternoon session. God bless you. So probably as Stella comes on board, we can clarify on the probably the next session on this and also the CPD point. So God bless you and over to you, Stella. Thank you.
Thank you very much, Grace, for quite a wonderful moderation of this session. I believe we've learned a lot, and we really want to thank our presenter, Odur, for really diving into the PSQI and giving us great insights that we can take back and use in our facilities. So just one more request, please fill in the exit survey. It will help us know what topics you want to learn better. If you want to reach out to us, we can always come to your facility and do an audit and also just work with you. And for the next series, so we'll be having this webinar series, we'll be organizing these webinars. And in the next 7 days, we will share information in your email. I believe when you registered for this webinar, you shared your email address. So we'll share all the details. We'll share the slides. We'll share the recording. We'll also share when the next webinar will come. And also based on the feedback that we'll receive from the exit survey, we'll be able to customize individual information to your inbox based on what your needs are. So as you fill the exit survey, you realize there's the last part that says anything you'd want us to bring to the conversation. So feel free to tell us everything you need, and then we'll share that in your inbox as well within the next 7 days. I hope that clarifies on CPD and also on when the next webinar will be. Otherwise, I really want to appreciate you for joining us. From me, Stella Oiro, our PSQI Associate at Systems Evaluation, we really appreciate you for joining and also learning from this session. Otherwise, thank you, and over to you, Odur, for your last remarks.
Stella and Grace, you've said it all. Mine is just to thank our members, thanks our colleagues for finding time to join us on matters CPD. We are working with the various regulatories to ensure that when colleagues join, they are able to have some of these accredited as CPD points. So in due course, once that is done, we'll be able to apportion these points, and especially now that, for example, for